Today we'll be highlighting some of our work, demonstrating how the application of data science techniques applied to neuroimaging and electrophysiological data could benefit those living with epilepsy. We begin the presentation with Alex's story. Back in 1976, when ABBA were topping the UK music charts and the first Rocky movie was released, Alex, aged 14 at the time, had one thing on their mind: passing their O-level examinations and enjoying the summer holiday with friends. On a seemingly normal day in school, Alex was walking home when suddenly and unexpectedly they had a seizure. After a second, more severe seizure, Alex was diagnosed with epilepsy, a neurological disorder characterized by sudden and recurrent seizures associated with abnormal electrical activity in the brain. In fact, Alex was diagnosed with temporal lobe epilepsy, the most common form of focal epilepsy, where seizures are believed to originate from a single part of the brain. Since Alex's diagnosis, 30 years have passed, and in that time Alex has been on 15 different anti-epileptic drugs, and not one has been successful at controlling their seizures. As it turns out, Alex, like 30% of all other temporal lobe epilepsy patients, is drug resistant. As a result, Alex experiences seizures on a daily basis, meaning something so normal for us, such as driving a car, would be impossible for Alex. After years of not knowing when they may experience the next seizure, Alex developed mental health conditions and began to feel increasingly isolated. However, this is not the end of Alex's story. There was one more option available that could prevent any future seizures: a surgery in which part of the brain believed to be causing seizures is removed. Before proceeding on to surgery, multiple sources of data are collected relating to Alex's brain. In this presentation, we will focus only on three. The first and most commonly acquired data is EEG. Here, electrodes are implanted onto the scalp or placed directly onto the surface of the brain in order to record the electrical activity in different regions. Second, an MRI scan of the brain is taken. A 3D snapshot of the brain, an MRI predominantly is used to identify any changes to the thickness and volume of brain tissue. Finally, we have diffusion MRI. Similar to a standard MRI, it too captures a 3D snapshot of the brain. However, it is used to quantify the degree in which water diffuses across the pathways within the brain, providing insights into the connection strength between pairs of regions. With all the data collected and assessed separately by the relevant departments, a group of clinicians discuss whether or not Alex would be a suitable candidate for the surgery, and if so, precisely which tissues should be removed. For Alex, it was decided that they were indeed a viable candidate for surgery. Unfortunately, even after this invasive procedure and the removal of tissue highlighted by the red marker, Alex's surgery was classified as a failure. Although the frequency of seizures was reduced, they were not completely suppressed, and Alex continued to live not knowing when the next seizure might occur. This is why our work is so important. During the pre-surgical evaluation, what happens if it is difficult to identify which tissue to remove, or if two sources of data disagree? How then should the clinicians proceed? What if we can apply data science techniques in order to better understand the underlying mechanisms of epilepsy and develop potential biomarkers which could be used to aid in the treatment of epilepsy patients or help guide discussions in the pre-surgical evaluation? That way, if we went back in time to Alex's surgery, we could ensure a better chance that they can achieve seizure freedom. To that end, my work has focused on deriving multivariate measures of abnormality and relating them to epilepsy duration. Understanding if and how epilepsy changes as a function of time could allow us to gauge where an individual lies relative to others and help identify potential biomarkers of epilepsy risk. In order to assess the relationship with duration, I decided to initially focus on a single source of imaging data, diffusion MRI. As mentioned previously, it allows us to map the pathways within the brain and quantify the strength of the connection between region pairs. As Alex is believed to have temporal lobe epilepsy, I only focus on the connections that are known to be commonly involved. As connection strength can vary even within healthy subjects, I standardised the data relative to controls to create a measure of abnormality for each individual pathway. We can see that in the orange pathway, Alex does not appear to be too abnormal relative to health, whereas in contrast, for the purple pathway, they appear to demonstrate a strong abnormality relative to controls, suggesting this pathway could be involved in the generation of seizures. For a group of patients, the abnormality measures per pathway are subsequently correlated with epilepsy duration in order to assess the strength of an association. However, as each pathway is considered separately, multiple comparison corrections are required, resulting in inconsistencies in the literature and true relationships being masked. However, does it even make sense to look at each pathway separately? We know from the literature that a strong covariance structure exists within the brain. What affects one region will have an effect on the others. Does it not make more sense then to combine multiple connection strengths into a single measure of abnormality? From the figure, we can see how the covariance can affect abnormality measures. For each individual region, the red and green point would be considered abnormal relative to the reference distribution in blue. Suppose the red point is Alex and the green a different patient. It is clear here that overall Alex is more abnormal relative to health. If we simply combine the abnormality measures together using the Euclidean distance, we do not see a difference in the two subjects. It is only after accounting for the natural covariance structure using Mahalanobis distances do we see a difference. Beyond epilepsy and neuroimaging, the Mahalanobis distance is primarily used for outlier detection. For example, it could be used to see which customers are more likely to purchase a product, given that you have knowledge of other customers who have also purchased that product. Alternatively, you could see which customers are less likely to purchase the product, and identify the key contributions to that decision. Using Mahalanobis distances estimated by combining multiple pathways in the hemisphere where seizures are believed to be originating from, I have already demonstrated a strong positive association with duration. This finding reaffirms the belief that epilepsy is indeed a progressive disorder and complements the work previously done in a univariate setting. Further work is underway to see how multivariate abnormalities from other sources of data relate to duration, or whether or not the harmonization of data from multiple sources demonstrates stronger associations with duration. Additionally, we hypothesize that these measures of abnormality could in some way be predictive of surgery outcome. For example, we can see that Alex shows a strong multivariate abnormality relative to health, perhaps indicating a successful surgery. Or perhaps it suggests that Alex is deviated too far from health and is unlikely to have a successful surgery here. However, further research is required to test these hypotheses.
Another approach we could take is to use a technique called network analysis. So far, Tom has talked about using a single modality diffusion MRI, but we can incorporate a second modality into the analysis to potentially provide a broader picture of the disorder. So we can take a 3D image of Alex's brain and split it into 82 regions, which are defined based on both their spatial position and their function, and we can calculate the volume of each brain region. At the same time, we can also map connections between different brain regions, as Tom described earlier, and infer the strength of the connection between each pair of regions. So brain regions which are nearby and part of the same functional network might have a strong connection, whereas regions which are far away might have a weak or no connection at all. This allows us to model Alex's brain as a network. In this case, I've done it using the StatNet package in R, with individual regions as nodes and the connections between regions as edges. This allows us to take advantage of a mathematical framework called network analysis or graph theory. And this is typically used in wider industry, for example in traffic analysis, to find roads which are vulnerable to traffic accidents, or in Spotify's Discover Weekly recommendation system. Now, we take a subnetwork of the temporal and subcortical regions, which are a collection of brain regions typically involved in temporal lobe epilepsy, and we show the connections between these regions. So one of these tends to be where the seizures start from before spreading to other regions. So this is for Alex's brain, but we have similar data for about 100 healthy controls, so we can define what normal looks like for each node in terms of its volume, and each edge in terms of its connection strength. We can see that Alex has 2 different brain regions which have abnormal volume, and 6 connections with an abnormal strength, and these abnormalities are likely to be related to epilepsy. A key discussion in Alex's pre-surgical evaluation was likely to be around which brain regions to remove. The key thing we want is maximum effectiveness, so seizure freedom, but minimal side effects. Different brain regions obviously serve different functions, so we don't want to remove more than is necessary. But what does that look like? Resection A removes both of the regions with abnormal volumes and some of the abnormal connections, but this may not be enough to guarantee seizure freedom. Alternatively, Alex could undergo resection B, which removes every abnormal volume and connection in the subnetwork. This has a greater chance of seizure freedom, but more unnecessary and healthy brain tissue may be removed. My current work can be summed up with these 2 aspects. Can we incorporate data from 2 sources to improve our understanding of epilepsy and how it spreads? In the field, we know that patients have volume and connectivity abnormalities, but how do these interact, and how does that explain the progression of the disease? Does the disease spread from region to region, causing abnormality in the connection between them, or does it spread by some other mechanism? This has the potential to allow us to improve treatment and to be able to better predict outcomes after surgery, and for surgeries which aren't successful, answer the question, why not?
A third method for studying neurological disorders like epilepsy is analyzing shape. We can use the MR images, the anatomical images of the brain, to create 3-dimensional representations of it. Here we're looking at the right hemisphere of 2 subjects, Alex on the left and a healthy subject for comparison on the right. We can see just by looking at them that the 2 brains are shaped slightly differently. We also know that Alex keeps having seizures. Their brain is dysfunctional. It is known that this affects the brain's morphology, but it's difficult to quantify this difference in shape when it concerns an object as complex as the human brain. So what are useful and interpretable measures to describe and summarize morphology and compare individual subjects? Can they give us any insight into the disorder, like epilepsy in Alex's case? Questions on how to numerically describe complex shapes also arise in other application areas, like facial recognition and computer-aided design. 3 measures that describe the shape of a brain are visualized here. The first 2 are surface areas. The yellow line is the surface of the gray matter that's visible from the outside. It excludes any folds in the cortex. The red line is the total gray matter surface area. And the average distance between the white and the gray matter, so the red and the green lines, is the average gray matter thickness. Recently, I've developed a method to compute them for each point on the cortical surface. This was done by defining a small patch with a fixed radius around each point, and then computing the measures only across points within this area. By doing this, I was able to show that the 3 measures of average thickness, total and exposed surface area covary tightly in these small patches according to the universal scaling law of cortical folding. In this plot, each dot is 1 point on the cortical surface of a subject. The confirmation that the scaling law holds is visible in the alignment in the plane with a slope of 1.25, as predicted theoretically. The covariance of the 3 measures at this level can be used to define new interpretable variables derived from the scaling law, one of which is the tension acting on the cortex. This tension, so a combination of the original 3 variables, differs regionally for a group of patients with right epilepsy, including Alex, compared to a group of healthy controls. Areas in blue mean that the patients with epilepsy have higher than usual tension, and in red areas the tension is weaker. Maps like this show us very localized effects of epilepsy across the cortex and help us gain a better understanding of the underlying processes. The variable capturing tension is a completely new measure that might be useful as a biomarker to find regions where seizures originate. We can use morphological data to show that the cortex folds locally according to the scaling law. This allows us to use new, interpretable measures of morphology to summarize and compare the complex shapes of brains. The data also shows us in what way different areas are affected differently by epilepsy. This helps us understand the underlying processes better.
So far, we have seen methods related to imaging modalities. Another approach for epilepsy evaluation is to use time series analysis. Another tool that researchers use for exploring the processes involved in epilepsy is the electroencephalogram, or EEG for short, that tells us how active the brain is. This tool will be used as a diagnostic tool for epilepsy, but also as part of the pre-surgical evaluation in order to monitor the normal background activity as well as the pathological events such as seizures for long periods of time. Depth electrodes are implanted directly in the brain and record the electrical signals when brain cells are communicating with each other. The brain activity is measured in the order of milliseconds with a good spatial resolution. Typically, EEG signal doesn't detect the activity of a single neuron. It rather captures the activity of large groups of neurons that are active at the same time. Each group of neurons is associated with a brain region. The activity of these groups of neurons is represented as waves over a spectrum of frequencies and amplitudes over long periods of time. Analyzing the underlying brain states from EEG, we can explore processes and their characteristics that shape the neural activity during a seizure and affect seizure severity. Alex experiences seizures daily and especially during sleep. It seems that there is an underlying daily rhythm in the occurrence of the epileptic events. Daily seizure cycles are well established in the literature, but there are longer time scales that influence seizure occurrence as well. However, seizure occurrence is not the only feature that change over time. Seizures change over time in terms of their spread, duration, spectral properties, and this affects seizure severity. More importantly, these changes also arise in a periodic nature. Alex would have a severe seizure every 3 days. During these seizures, Alex would experience loss of consciousness accompanied by jerking movements of the arms and legs. In the time in between, Alex would experience a less severe seizure. During this seizure, Alex would feel just a minor shaking. In order to explore the temporal diversity of seizure characteristics, I'm analyzing ultra-long-term signal data from different parts of the brain and investigate how the fluctuations on different time scales of background neural activity are associated with seizure characteristics. All the different approaches we have presented so far can help us understand better epilepsy. Being able to accurately localize the origin of the seizures can lead to 100% surgical success rate and completely render a patient seizure-free. Also, for patients that surgery is not an option, understanding the processes that affect the timing of seizures but also how seizures change through time can lead to predicting seizures and their severity. This can help us control seizures through adaptive treatments. These solutions can have an impact on the quality of life of patients with epilepsy, just like Alex. For Alex, being able to gain control over his life and engage to everyday activities, like driving a car or socializing, can make a huge difference in his life, can live a normal life without the fear of experiencing a seizure at any time. Thank you for listening. We are happy to answer your questions and chat with you during the poster session.